and he's found the pointer.
Yeah. Thank you. And I'd like to thank Julio and all the organizers for this great workshop. It's been quite the experience, and all the participants for making it such a great experience. We've talked a lot over the last few days about the cascade and engagement of people into care, and I'm here to talk about how perhaps we should pay more attention to men as we try to engage people into care. As we try to increase the number of people on ART, we often target particular populations, and in Africa, often this has been targeting women and children, particularly because women represent a more vulnerable population, whether it be through biological susceptibility or the gendered power dynamics. But there's increasing evidence that men are being left behind, whether that be at the level of HIV testing, of treatment or care. And if we were to target men and improve the outcomes for men, there could be a lot of positives that come out of it. The obvious, which would be new infections and increased survival, but there could actually also be some economic outcomes that come out of it. So in order to drive this point home, we don't need to look much further than the outcomes of care. I'm going to start with another study, not the study that I'm here to talk about today principally, but a meta-analysis, recent meta-analysis that some of the people that I work with have completed that I helped out with. And the aim of this meta-analysis was to look at the effect of gender on survival across sub-Saharan Africa, particularly in participants enrolled in antiretroviral treatment programs since the rapid scale-up of ART. And so this data is for 216,000 patients or participants from 23 cohorts in 14 countries. And what we found is that overall, men are at higher risk of death with a hazard ratio of 1.37, so a 37% increased risk of death in comparison to women, and it's very significant. There are a few cohorts that lie on the right side of this line, indicating that women are at higher risk of death, but none of those are significant, and the majority of the ones on the left are significant. So there is evidence that men are having worse outcomes. Also, there is some evidence that men are underrepresented, with many cohorts having below 30% of their cohort being men. So why such worse outcomes? Well, there are all kinds of reasons we can think of. We can think of later initiation treatment. We can think of men being less likely to engage in care, or lower retention rates. We could also think of adherence, but there is evidence in the literature that in some cases women have lower adherence, so I'll leave that out from this discussion. So the study that we looked at, we had two objectives to our study. One of the things that we need to acknowledge is that there is a fundamental difference between how women and men engage in care, and of course that's antenatal care. It's a fundamental difference that we need to acknowledge. So I wanted to look at, because a lot of people think that the reason that women tend to start care, or one of the reasons for this discrepancy, is antenatal care. So I wanted to look a little closer at that. And then the other thing I wanted to do was concentrate on the first point from my last slide, which is late initiation. So as the delegates from Swaziland discussed yesterday, they talked about a large discrepancy between the baseline characteristics of men and women, and they've actually been putting effort towards engaging men, and I was quite happy to hear that. And they talked about a discrepancy of around 40 cells per 40 cell counts between men and women. So what I want to look at is quantify the impact of late initiation on these worse survival outcomes that we're seeing in men. So this was in Mildmay. So the cohort I worked with is Mildmay in Uganda. It has one principal center and works with many clinics in the region just west of Kampala. It's been open since 1998. It opened originally for palliative care, and since 2004 has been part of the rapid scale-up of ART. And one of the things that they have is really advanced laboratory capacities, which is great, because they have somewhere around 60 to 70 tests per patient that they run. So lots of interesting clinical data from Mildmay. Now for this study, we considered 4,789 clients. we only consider people who initiated ART from January 2004 to April 2011. But the study ended in 2011. I wanted to leave enough time for us to be able to observe survival outcomes. And I'm just going to note here, because there's actually this third factor here, completing a screening form. So the data come from lots of different forms. The screening form is a form that's filled out just before starting ART, and that actually knocks out 2,000 observations, so it is a bit of a limiting factor. But the reason I've included this request, the reason I've included this is because it contains the information on whether a person initiated treatment through antenatal care, and it also contains WHO disease stage, which talks about disease progression at baseline, which is of interest here. So all in all, we removed 238 out of the 3,107 women for either reporting being PMT-CT eligible or being pregnant at baseline. And that represented 7.7% of women. When I talked with our people at Mildmay, they seemed to think this was a fair number. I know that with my work in South Africa, this would seem to be quite small. Okay, so the first thing is to look at what are the differences between men and women once we've removed women who initiated through antenatal care. And we still find a very important difference between the disease progression of men and women even after this removal. So men tend to have a higher probability of starting with WHO disease stage of 3 or 4 versus 1 and 2, with a 10% difference and an odds ratio of 1.46. And men tend to start with a lower CD4 than women, again, a very strong effect. Now, when you do a sensitivity analysis, and I should have probably included this here, if you include all of this 6,000 some odd people and you do not remove antenatal care, women who initiated through antenatal care, this difference becomes much more important. It becomes more in line with what was reported yesterday through the Swaziland people, around 40 instead of 25. So antenatal care does represent a difference in how men and women are, or in why there's such a difference between men and women in terms of disease progression at baseline, but not entirely, and I think that's something that's worth noting. So all in all, we had a median follow-up time of 3.25 years, and 188 persons passed away. And now we move on to the second objective, where we're trying to quantify the deaths, the additional deaths, the additional risk of death caused by this advanced disease progression at baseline in men. So what we're doing is a basic epidemiological modeling, which is a mediated model. So rather than just look at the effect of gender on death, we're looking at gender through baseline CD4 and WHO disease stage towards death. And one of the major concerns we have in these types of modeling are feedback loops, but of course, if you think about this, there's no way that any of these arrows are going the other way. So they're all one-way arrows, that's nice. So the first approach I used, and it was the approach I actually used when I sent in the abstract for this talk, was to use a cross-proportional hazards model, which is what most people do, and to just fit it with the mediators and without the mediators, and take a look at the proportion, the difference in your coefficient, and take that as how much of the effect is being explained by the mediators. And when we do that, we find that gender has a significant effect when on its own, or with covariates in this case, with age. But when we add the disease progression stages, we find that gender is not significant anymore, and roughly 40% of the effect of gender appears to be explained by these mediators, by the CD4 and WHO disease stage. Now, one of the disadvantages of this approach is that you can't really interpret it from a causal standpoint, and also you can't build a confidence interval for this difference, which is a bit of a limiting factor because we don't know if it's really significant. One of the advantages is that it does allow us to include WHO disease stage, which my next analysis does not. I'll explain that in a second. Also note that the hazard ratio for gender appears to be very similar to what was shown in our meta-analysis, which seems consistent, which is always nice. So what we want to do is, what I set out to do is to dissect the total effect of gender on death into the direct and indirect effect. And let's take this direct effect with a grain of salt for a second. I'll talk about it in 1 minute. So what we're trying to do is do causal modeling, so through a counterfactual standpoint. So the idea of a counterfactual approach to modeling is to model as if everyone were men and then as if everyone were women and compare the results. And ideally, that leads you to results that are similar to an RCT, where the only thing that you're comparing is men versus women instead of subject to all kinds of other things. The counterfactual approach does require some pretty strong assumptions that can never truly be verified. It requires that you include all confounders, but requires that you also don't include exogenous variables, as they can add bias. Now, I haven't included the confounders on this road here because traditionally when you are doing a counterfactual type of approach, what you have is acts as a treatment. And I'm not looking at gender as treatment. I'm not really interested in knowing the true effect of gender on death. I know that that's being explained by various other factors like adherence and retention to care and all these things. What we're actually trying to do here is tease out, from this arrow, tease out the amount, that the effect that's coming from baseline characteristics or disease progression at baseline. And so what I did is used an Aylan regression model rather than a Cox regression model. It's pretty flexible as well, but it's going to be, instead of looking at hazard ratios for the individual, we're going to be looking at mortality rate for the population, but that still answers our question. And so when we do this, using the Aylan model, what you get is, instead of, you get a mortality rate rather than a hazard ratio, as I just said. And so what we're measuring is the amount of deaths per 10,000 person years. And if this cohort were entirely composed of men rather than women, we would experience an additional 45 deaths per 10,000 person years based on that. And when you decompose that into the effect due to just gender on its own, I guess with those other factors that I mentioned, versus the one that's caused by their lower CD4s at baseline, this does not include WHO disease stage, we find that 40% of these additional deaths in men is explained by the fact that they're entering care at much later stages in their disease progression. Okay, again, attributable, take that with a grain of salt. It's an observational study, but we're coming from a counterfactual approach. So in conclusion, throughout much of sub-Saharan Africa, men have an increased risk of mortality. In our cohort, the increased risk of mortality can in part be explained by the more advanced disease progression at treatment, and the more advanced disease progression at treatment does not seem to be entirely explained by the increased engagement of care into care due to antenatal services. So we need to act up. So how can we better engage men? Actually, I think the best idea that's been brought up is the one Nathan talked about, which is home-based testing. It seems that home-based testing would be a great way to getting men into the system, which is the first step. But ideas that have been thrown out are using circumcision clinics as testing centers, continuing to encourage men to get tested with their partners through antenatal care. Rwanda has shown good results there. And one of the approaches that I found really interesting that I came across was church-based approaches. I know that in Uganda and a lot of Eastern Africa, that would actually be quite, that seems like a very promising way to go about doing things. And I'd like to thank you.